Oh, there we are, live. Hi, Jason Konner is joining us today at Psychedelics today. Jason, how you doing today?
Nice to see you, Joe. I'm doing good.
Good. I'm happy to be connected with you. We got connected through the upcoming conference at Penn that everybody should check out, and your name popped out at me. And it's not often I see people affiliated with oncology involved in psychedelics. I know of maybe one in vivo trial, um, and that's it. So really excited to dig into your work and happy to learn about you. What are you up to now? What's your are you in practice anywhere in particular?
Yeah, I recently actually left my clinical practice. I was at Sloan Kettering for about 24 years until August, where I transitioned to a consultant role so that I can commit myself full time to working in this area.
That's outstanding. And you were a full-time oncologist for how long?
Yeah, I came to Sloan Kettering in 2001 as a fellow shortly before 9/11.
Hmm,
Did my fellowship and stayed on and became full faculty and was there for over 20 years.
outstanding. And how how did psychedelics come on your radar of something of interest?
Well, I would say my first introduction to them was just a friend who had recommended I read Michael Pollan's book. I think
Mm,
like so many others, and I read the book and I said, "Hey, this actually sounds really interesting." I didn't know any of the information that was presented in there.
mhm,
For me, it was just another drug. I was a pretty straight guy for most of my life, and really had no understanding of what psychedelics were.
mm,
So
that's
it piqued,
interesting.
yeah, and it piqued my interest. But from my vantage point, I had no idea, if, how, or when I would ever have an experience or what that would look like. So
Mm,
nothing really happened. Um, and then I had an experience where my dad passed away, and witnessing his process, witnessing him having hallucinations, which he actually told me were the only easeful part of his journey. Actually, a light sort of pinged on when I heard that, and he really got very connected with love. He really just had an amazing journey of his own, just the dying process.
mm,
Um, and after thinking about that experience and that, in some way, an altered state of consciousness gave him a sense of peace. Uh, that's really the extent of my understanding of things. That really piqued my interest, and I reached out to some of the people at my hospital saying, "Hey, we should study this," and I didn't get much support around that, and so not much happened.
mm,
Um, Life went on. Being an oncologist is not easy. It comes with a lot of challenges, not just in how demanding it is, and it's extremely demanding, but in what we witness. We witness some extremely difficult things, and we walk astride patients for many years, and they go through just incredible hardship, and often will die of their disease. And we have very little support or training or understanding about what sort of personal work is required in order to be able to do that work, uh, and be supportive for patients and also be supportive for ourselves. Um, and so that's sort of lurking in the background with you when you're a medical oncologist. And then COVID came, and COVID was really difficult for a lot of people in the medical field. Uh, and that brought me to the end of 2022. I was pretty burnt out. I was sort of emotionally in a bad place. I was spiraling, and I developed an inguinal hernia, and
mm.
I scheduled a hernia surgery. And I actually took 2 weeks off of work for this hernia surgery. And as it was coming, and they said, oh, you're going to need to not do yoga for 6 weeks, and you won't be able to exercise. And the days were getting dark, and it occurred to me I hadn't taken 2 weeks off in over a decade. And I really wanted to do something for myself. And I had no idea what to do. I was too dysphoric to plan a vacation. And a week before my surgery, I was in a yoga class, and I overheard a woman, just a snippet of a conversation. I just heard a woman say, ayahuasca retreat. And I didn't know quite what that was, but something just immediately shifted in me. Whatever darkness I was going through just lifted right away. Just hearing that, I immediately knew that's what I needed to do. And I literally went home and Googled ayahuasca retreat. And the first thing that came up had, 12,000 5-star reviews. And I called them up, and a week later I was in the jungle, and I kind of slipped through a portal there. And, that was 3 years ago. And it absolutely, transformed my life in some pretty massive ways. I had no idea what ayahuasca was, or, what this was all about. But the week was just really transformative. I had some incredible highs, some extremely difficult, challenging experiences, and everything in between. And, really opened me up. And after that, I did another retreat with mushrooms, and really never looked back after that. And I realized that first year working as a medical oncologist was just extraordinary. I really felt like I had a superpower. I was really able to show up for my work in a way that I had never been able to do before. First off, my burnout had been both identified and lifted. And I say identified because I didn't even know I was burned out. I was miserable and didn't understand why, and ascribed it to so many other things in my life. But the experience with the ayahuasca really showed me exactly what was going on, and I understood things on a much deeper level. And in addition, I had, a pretty profound fear of death prior to that. And that was gone after my experience, which just is incredible. I never could have really imagined that. And I think as oncologists, so often we come into the profession because we see cancer and death as a bad thing. And we're basically in there to sort of ward it off, or prevent it, or push it kick the can down the road as far as possible. But we're often projecting our own fears into the room where with patients. And suddenly when that was resolved, I was no longer doing that. And I think prior to my working with ayahuasca, there seemed to be two options when you're working with sick and dying patients. And one is to remain compassionate and connected, and ultimately suffer the consequences. People cry in the bathrooms, they have bad dreams, they're hurting, they're burned out. There's all sorts of consequences to putting yourself out there like that. And the other option seemed to be just keep patients at an arm's distance as a form of self-protection. And that also doesn't really serve anybody very well. And I think with ayahuasca, I saw a third path, one where I could remain connected, compassionate, interested, present, and not suffer the consequences, because I had this new perspective on basically everything that served me so well. And it was extraordinary. And I heard from patients just amazing feedback. There was the depth of my relationships was just very evidently richer. And patients were really feeling connected. And I was able to have discussions about spirituality with them in a genuine way, not preaching anything, but just being able to kind of understand where patients are at with some of their more existential questions. Where prior to all this, prior to ayahuasca, I was really an atheist, materialist, rationalist, scientist. And if there's not evidence for it, I'm not buying it. and suddenly there was evidence for a lot. And so I was I was able to really genuinely have these sorts of conversations and connections with patients, and bring up a lot of material that previously had not really been addressed, and it was really deeply appreciated by patients. And it was amazing, and I was just so grateful, and it just absolutely changed my life. um, but there was a deep call in me to do more, and to share this in some way. I mean, how could I not? I just found this unbelievable type of healing, and I'm surrounded by people who are really stuck in the muck, of going through cancer, or supporting someone with cancer, in the place of sort of a narrow focus, or
Mm.
of an egoic mind. I don't mean that in a state of self-inflation, but in sort of a narrowed view of everything. So I think the first year it was really, yes, this is amazing. I'm so grateful. I'm so happy I can do this like never before. And then the next year was just like, I can't be the only one. I just can't be the only one. And I was able to, over time, just, it was clearer and clearer to me that there's a certain amount of suffering and grief and trauma and discomfort that's going to come along with cancer. I mean, cancer is horrible. There's a certain amount of pain that's going to happen no matter what. But then there's this layered suffering on top of that, in terms of anxiety about the future, and unfelt feelings, unresolved or unaddressed traumas. And there's so much that can be addressed that we're really not doing a good job as a field of addressing. And so much of what we do is spending time with these things. And so it became eventually impossible for me to do what I was doing with a clear mind, without, and knowing what I know of what is possible, and not be able to find a way to help, offer that, or bring that, or support people in finding, uh, similar relief.
Well, thank you. That was lovely, and what a journey. So, um, yeah, who said hernias weren't a good thing?
I never got it fixed. I'm very grateful for it every day.
So, I there's so many threads to pick up on here. So, you you came out of school, they're like, here you go, here's your patients you got to work with, help them to the best of your ability. But, through chemotherapies and other adjunctive therapies, right? It's not necessarily like, how do we make them feel good, or at least a little better? Not like we really can necessarily, but that's kind of what chaplaincy is about. That's what palliative care is kind of about. And you're saying you didn't really have those skills, right?
Yeah.
Like from training.
Yeah. And I mean, I think some of the newer training programs give it a little bit more lip service, and there's a little more attention to it, but not nearly enough. And I think I came to appreciate over the couple of decades that I've done this, but especially over the last couple of years, just how important the relational aspect is of our job as medical oncologists. I mean, it is absolutely such a cornerstone of the healing process. And I know that because my patients tell me this.
Mm,
But at the same time, we work within a system that does not support that, does not reward that, does not give space for that, does not give training for that. And it's to everybody's loss, because
mm,
there's so much that can be gained from that. But so many docs don't necessarily, not only is there not the time for that support, but also the capacity. How do you show up as a supportive doctor? And these systems that we have in place are really, really thin. And I don't mean my hospital in particular. I mean the whole system. I think sometimes you think you get a cancer diagnosis and suddenly there's a psychiatrist and a social worker and a chaplain and all these people in your corner who are going to be there, but it's really not that easy. A lot of people don't have access to all these things, and they don't have time. Very often people with cancer are working full-time jobs, and
Hmm.
they have a really demanding schedule in their lives. They're barely able to keep up with what they need to do to stay alive. Um, and many people are not open to having a psychiatrist, and many people go to a psychiatrist and don't benefit from it, because I think very often what happens is patients are diagnosed with a reactive depression, and they're given an SSRI, and it has marginal, if any, benefits, because they're not necessarily depressed. They're struggling with meaning. They're struggling with unlabeled trauma. They're living with grief. There's so much that the system does not even give lip service to. That really, there's so much potential for deep healing, because these things are just lurking throughout the journey.
Mm.
And also just the capacity to be present. When you get a cancer diagnosis, and I'm a cancer survivor myself, and I can speak to this personally, not only as a witness, but something changes. There's a light switch that flicks on, and suddenly there's this uncertainty about the future, and there's these existential questions are just there. Am I going to make it to next year? Am I going to grow old? Am I going to see this future that I once thought I was going to see? And um, so often we say, okay, well, you just got to live in the present, but that's a lot easier said than done for somebody who is living understandably in a really contracted state of fear and
Mm.
pain. And it's just, yeah. So we, as I was saying, very, very seldom are patients able to access these services. And when they do, they often don't serve them. Um, they go to support groups, and those are invariably harmful. I don't know if I've ever met a
Oh,
patient who wasn't
really?
harmed by going to a support group. Yeah, because what happens is, they're recently diagnosed. They're really looking for community. They're looking for support. They don't know where to find it. They're looking for peers, and they go to support group, and somebody who's really way worse off than they are is there saying, yes, I was once like you, and this, look at me now. And it's really awful.
Mm.
And it's traumatic. It's traumatic. I stopped referring anybody to those after a while, because it's invariably just an awful thing. So very often as medical oncologists, we are doing the work of the parent that is normally ascribed to psychiatrists, chaplains, palliative care doctors. This is our bread. That's what we do. We're managing pain, we're managing anxiety, we're sometimes treating depression, as best we can. And that's where a lot of the relational aspect of this comes into play too. I mean, if you're doing this well, but the way things are moving in medicine, that most people who are hired are administrators, and most of what we do at this point is on the computer for the sake of billing and lawyers, and our numbers are being crunched and our RVUs are being measured, and it's hard to really go in and give space for a patient to express themselves in a
Mm.
meaningful way. And what patients are going through is just like horrific. We tell them, oh, you've got cancer. The C word, carries a ton of weight. It's really just like a very powerful energy. Oh, and we're going to take apart one of your major organs, or parts of your sexual apparatus. We're just going to tear you open, put you back together, dump you with chemo, maybe radiate you, and maybe you'll live and maybe you won't. I mean, that's like a lot at once. It's a lot.
Hmm.
And so where the complexities of just the medical care are hard enough to keep up with, because it's a lot. Patients come in, they have multiple comorbidities, they're on multiple medications, they have really complex diseases, and there's a lot. So, you know, it's a difficult situation for patients, for families, for caregivers, for healthcare workers, and for survivors. So often when somebody is done with all this, we say, oh, okay, you had your breast cancer, we took off the breast, we gave the chemo, we did the radiation, here's some hormones, you're done. You're statistically gonna likely live, and we mark it off as a success. But very often this is where a journey begins, for a patient. Like, what the hell just happened? What just happened? What happened to my hair, my beauty, my nerve endings, my energy, my sexuality, my relationships, my job, my life?
Mm.
And so, and these are the survivors,
Yeah.
so often. So there's so many layers to this, so many layers. I could go on about, what we bear witness to, but it's a lot. And we need better tools for this. We need better discussions about this. We need a ton more support for this. And so after discovering what psychedelics can do, I'm just like amazed. And I say, oh my God. And then you go and you look at some of the data from Roland Griffith's work and at NYU and Yale and UCLA, and you say, oh, well, there's actually some data to say that patients with terminal cancer, their existential distress and anxiety is substantially eased by 1 or 2 sessions with psilocybin. And it's like, well, we should be screaming this from the mountaintops, right? This is big news. This is what we're doing, right? This is what is the B story of what's going on. This is why we're doing everything we're doing. Shouldn't we be talking about this? And so I really thought we'd be celebrating this as a field, and I would go to these conferences and there'd be absolutely no discussion of this at all in the medical oncology, surgical oncology community. There's no discussion of it, none. There's a little bit in the psychiatry community, which is great. There's some interest, it's getting there. But in terms of, there are these amazing data, but then there's the reality on the ground, right? What is it going to take for these data to make it to patients, right? Or is this just some abstraction? Or is this just a way that we're trying to get FDA approval for some of the new pharmaceutical variants of these medicines? And so initially I'm like, oh, well, let me participate in clinical. We need more data. But no, I mean, we've got data. We need bridges. We need action.
So one of my lady I kind of consider to be my big sister, she kind of, I think, for years led derm oncology at where the hell was she? One of the fancy Boston hospitals, and I think she's moving to Houston now. But when in conversations with her, the level of kind of flexibility oncologists have in terms of using really kind of far out things, okay, there's like one case study in the literature that says this other, like the standard of care and everything else we're trying just doesn't seem to be working. Like, we have the privilege of using this kind of thing. And there's this really interesting edge case, Jason, that happened in where was it? Denver, when Denver decriminalized mushrooms. There was I think it was an oncologist actually prescribed psilocybin under the, at that point, Trump Right to Try Act, federal Right to Try Act, because the person was stage 3, stage 4, like on his way out. And this patient actually went and did like a big press release about it. Like, I believe in this so much. It's not going to save my life, but it's going to really help me with have a full life for the next weeks or months. And I just love that case. And I wonder kind of your perspectives on this kind of, we have the federal Right to Try, Oregon's kind of working on some Right to Try stuff. Like, do you have any kind of opinions on this kind of Right to Try thing?
Yeah, I mean, Right to Try is a very bureaucratic process.
Yeah.
There's a lot of lip service about this as a political talking point, but in reality, it is so rarely applicable. It so rarely helps any individual, because the amount of work required by the system in order to allow this to happen, you basically have to write a whole new clinical trial for one person with a low likelihood of it coming to fruition. It's actually easier to write a clinical trial, which I've done. I have made clinical trials for individuals. And I would rather do that than the Right to Try, because at least you have a commitment from a manufacturer or something. You have some confidence it's going to happen.
Mm.
So in the reality, right, to try almost never comes to fruition, largely because somebody's in this situation, they need this sooner than the 6 months that it takes to go through the bureaucracy. It's a abstraction.
Right. And not all that meaningful. And that's interesting. So clinical trial might actually be more interesting in like how do we streamline access that way? The Canadians have like the whole federal petition process. I'm sure you've seen that a little bit, but it's their success rate is getting lower. But that's leading to a lot of lawsuits for the federal government to have to answer to up there. Yeah. Well, that's a really clever and interesting angle. Thanks for that. And I go ahead.
No, please go.
So there's a lot I want to get into with you. This is so interesting. I'm curious about insights from your own experiences. Like, do you feel like you perhaps think more clearly? I'm kind of removing the humanity part, but like when you're actually developing treatment plans for folks and administering the treatments, are you thinking perhaps more clearly or feeling like you're mm, engaging with the patient's condition in a more intelligent way? Are you feeling like you have more insight into how to approach it?
That's a good question. Yes and no. I think that I came to this work at a point in my career where I'm sort of at the top of my game cognitively about all this. I do think that this work did enable me to be more creative about what sort of clinical trials we could do,
Hmm.
more creative about scientific questions, more helpful in advisory boards and things like that. So and also your mind is just clearer. You're just less cluttered.
Mm.
So I would say that my capacity to be creative was definitely enhanced.
Hmm.
But I think there was also just more room for that because there's less clutter from distress about the other things that are part of the job.
Mm. Yeah. Well, I love that. That's cool. There's this whole field of study happening. This group, Center for Minds, is leading the charge there. They've been working on creative problem solving with psychedelics and trying to, get to the neurology of it. And I think I hope for an ecosystem of groups looking at that kind of thing, so we can have some more actionable insights sooner. But I do wonder what we're going to find when we look at that. Like, how are we actually potentially solving problems quicker or more creatively? Um,
I have
yeah.
no doubt there's something there. I have no doubt there's something there. Yeah.
All right. Before we go back to oncology and psychedelics, this idea that I have been kind of toying with for a while, and I think oncology is actually uniquely suited for this. So we have evidence-based treatments, right? Sometimes we don't have enough evidence-based treatments, or they just aren't working for whatever reason. And then there's this concept we've been kind of playing with here called evidence-informed decision framework, where we're like, okay, like we're kind of stuck. We don't know like what's happening over in these outer territories, and can we infer things laterally from those? My
Mhm.
friend Court Wing's always like referring me to this kind of evidence informed. Is that a thinking style you have to work with in your practice at all? This kind of lateral jump.
Yeah, I haven't heard that term, but I like it. And it is descriptive of what much of what I do. I think it depends to some degree on which field you're in. So for instance, in breast cancer, there's so much data that describes almost every scenario of every patient at every stage of their disease. And that's largely because we have pharmaceutical companies who are investing in trials to try to, get a foothold in every point of the disease. There are these trials that have thousands and thousands of patients, and
Hmm.
they look for, statistical significance in these groups, and you could look for subtle differences. And then the argument is made, well, we have, so many hundreds of thousands of cases per year that each incremental benefit is justifiable. So you have those fields that are very data driven, And then in my field, I worked as a gynecologic medical oncologist. So my patients had gynecologic cancers, almost all of which are really rare cancers.
Mm.
And so you're very often in a data-free zone where you need to be evidence informed. I think what often happens in these cancers is there is a bit of a gold rush for the pharmaceutical industry to get data, but very often they're trying to get their drugs earlier and earlier into the disease process. So they get a little data that, yes, it works in recurrence. Let's move it to the front. And because that's when they're going to get the most use of their drug. So for the first line or two of therapy, there's going to be some standards of care. But very often, I would have patients who would have 10, 15, 20 lines of therapy. So for the number 3 through 20, it's evidence informed. And that's where the creativity and where the art of medicine really comes into play. And the relational is absolutely critical for that as well, because you really need to get a good sense of a patient's preference and needs. And there's a dance about understanding what they're capable of and what their toxicities are, because very often, they may want to underplay one thing because they want a certain drug, or, you have to really feel out what their preferences are, how not to do harm, how to work for them. So there's a lot of, this is the art of medicine plays deep in these settings. And ironically, the more we know scientifically, the bigger that field of data-free zone gets as patients are living longer.
Yeah, I was chatting with I think it might have been an oncologist recently about that, or just the new diseases that are happening post-treatment because people are living, oh, you've survived 30 years after your chemo. It's novel. Like we don't have data sets for people living to 100 after having these treatments. So it's a fascinating area of study. Mind-boggling levels of complexity. And it's like you're not going to find a big cohort you can study that's like that. You're not finding thousands of people with that, situation.
Yeah.
So it's going to get more and more complex, I imagine, as people continue to age here.
Absolutely. And yes, what you bring up is a really interesting point. I've thought about this a lot, about these new disease states that never really existed. I mean, you look at something like graft versus host disease, which is a consequence of bone marrow transplant sometimes. And that never existed before we had bone marrow transplants. And suddenly it's this whole new disease entity. And people specialize in this. And it's just interesting as physicians to be treating diseases that we've sort of created. I mean, they come from helping people, but also we've created them. And there's something really strange about that on some level, just almost existentially from our perspective. So it's interesting, but unusual.
So in your interest in psychedelics and knowledge of assorted chemotherapies, radiation, other interventions, are you curious about or hopeful about assorted psychedelics or psychoplastogens, neuroplastogens to actually recover people's nervous systems in some way? Like you're kind of talking about like blunted kind of nerves earlier post-treatment. And I wonder about your perspectives there or hopes there.
Yeah, I mean, it's a great question. And I so often get the question about what are the biologic effects of these agents going to be, and the need in terms of peripheral nervous system neurogenesis in oncology is tremendous. We have so many chemotherapies and targeted therapies as well that are damaging to the nerve endings, and that really impact quality of life. And these things are hard to graph. But when you're with patients and you hear how it affects their lives, you see, how substantial an issue this really is. And the fact that we can see increased growth of synapses, that we see regeneration of nerves in the brain, with some of these substances is another thing that I would think the medical field would be shouting from the rooftops, because we're all taught in medical school the brain, maxes out at age 24 and then slowly atrophies over the next several decades, which is kind of a depressing thought. You do see brains shrink on the scans as patients get older. So suddenly we have something that seems to beef up the good cells and the good parts of the brain. And it does open up the question, well, what are we doing for the rest of the nervous system? And this is something, Paul Stamets certainly talks about. I know that his Stamets stack, he thinks a lot about how that might affect peripheral neuropathy and nerve endings. He talks a lot about this TAP test that he looks at with people in the Stamets stack, which, is a surrogate perhaps for peripheral nerve function. But this is something we really need to study. I mean, this is so understudied. And the medications that we have to treat this, the gabapentin and Cymbalta, and they don't actually improve the problem at all. They blunt some of the discomfort. They do nothing for numbness. They can blunt some of the pain, but they have their own side effects. And this is such a huge need that it needs to be studied. And I think there can be fairly straightforward studies to look at what happens to, the synapses of peripheral nerves when they're exposed to psilocybin and lion's mane. Like, what's going on? Show us. And I think that might generate some interest in that. But I think it's hard for me to say that it does or does not do that clinically, because that's hard to study. Certainly from a one person's perspective. These are very slow growing nerves. The peripheral nerves can be a meter long, especially in the legs. So axonal regrowth can take months to years. So it is hard to study the clinical effects of these things.
Yeah, I remember Paul kind of pointing to a lot of Japanese studies. I just wonder if they're like looking at mushrooms in a different way, or like they're looking at these in petri dishes as opposed to in humans, and kind of doing that inference to humans. And it's always an interesting one.
Yeah. Well, certainly in East Asia, they have a wider appreciation for what mushrooms can do, and they also use much higher doses of medicinal mushrooms. So I think the medical community in Japan has, certainly embraced mushrooms just as a therapeutic modality more than we have here. So
does the science seem global? Like, does it? So I remember kind of wading through all sorts of weird, murky international science, I don't know, snarkiness, maybe, like inability to accept other countries' data. You're like, oh, the Germans do this, or the Russians do this, Chinese do this, and it's not real. And like, I found that like not a helpful approach. Like, okay, what's here that's actually of value, and how do we go forward? Like, what can we actually take from this, even if it's not our standards?
Yeah.
Is there good cooperation?
Yes and no. I mean, it's totally subjective. When you see a European study that shows something novel, you could say, okay, this is great. Or if it goes against your bias, you could say, well, this was in a totally different population. We really can't accept this. So people tend to accept or discard them based on their own biases, is what I've observed.
Yeah, that's interesting and helpful. Yeah, thanks for that. And I'm particularly hopeful, sorry, about what ibogaine might hold here in terms of what I've seen out of Gouldelin's labs, and this kind of just extreme length of neuroplasticity, like 4+ weeks. She had to actually terminate the trial before it hit the end of that window. So they're like, it just keeps going. All right, stop. It was only 4 weeks. And it could have theoretically been a lot longer. Like, we don't really know, but it's really hopeful to me. We'll see.
I mean, ibogaine is really having his moment, and I think that it doesn't necessarily have the stigmas that some of the other substances do. So it seems to be welcome.
Rick Perry did it. Yeah.
Yeah. And
And I'm
for
going
what
to the
it,
Ibogaine Summit on Friday. That's in Aspen, which should be really interesting. And I'll come back with some findings there. It's kind of like a private, kind of like Texas influenced big conference. It'll be fascinating to see what they want to talk about.
amazing, amazing. Yeah, I mean that would be incredible to look at. I know people are starting to microdose ibogaine, and the different ways of working with this medicine. So who
It's
knows? I'm not.
fascinating.
It really is.
I'll speak to it in terms of microdosing, and it's a very curious experience. I don't
Mhm,
know how to characterize it all that well yet, but it's fascinating.
mhm.
And I think edgy. So be careful, everybody. Like talk to a bunch of doctors about this before you jump in, because there is a cardiac risk there, and we don't want anybody to get hurt. Yeah.
Agreed.
So another interesting thing about this kind of would you call that peripheral neuropathy, when people just aren't having really good nerve function at the ends of the nervous system?
Yeah.
Yeah. We had this really interesting case that we worked on. A friend kind of did the work. It got published. She's been really public about this from the patient experience. Lynn Watkins is her name. Couldn't move her toes for a super long time, couldn't drive, couldn't use utensils, 10 out of 10 pain forever, kind of a surgical accident that just compounded and compounded and compounded. And we did, my friend did this treatment, and 6 weeks of prep, then a dosing session, and she could move her toes again. She could do that like PT towel test where you're actually moving. She had never done, in ages, and in utensils. Now she can drive herself to the store, go shopping on her, all this stuff. They're fascinating. And everybody should check out that story. I wish I had the article where I could like cite the paper for you, but it's if you're curious, I can send that your way. But it's,
I would be curious.
yeah, I'll dig in. I'm a founding board member at the Psychedelics and Pain Association, and we do a lot of really interesting stuff, like bring people together, top folks in science and medicine, and actually patient populations. We're trying to bring patients together to say, what, I'm stuck. I haven't had help in 5 years. The stuff they give me is horrible, and I don't feel progress. What do I do?
Yeah.
And in some cases, decades, right?
Hmm.
But the hope is, how do we just keep people from using opioids for decades of their life when there could be alternatives?
Yeah.
Hopefully, fingers crossed here.
Yeah.
Yeah.
Absolutely.
So sorry for that tangent on my stuff, but the idea here around like this intersection of psychedelics and oncology is super interesting and broad ranging, right? It's, some people might die, some people's family might be more impacted than they are. And I'm seeing a lot more stuff around, okay, I'm going to get the treatment, but maybe my spouse who's going to survive me also should get a treatment.
Yeah.
And she can
Abs-
maybe show up better for me.
yeah. Absolutely. I mean, caregivers have it rough, because they can't really complain
Mm-hmm.
in some way, uh, and yet they're very often giving a lot, and it's not their life who's on the line, but it's their partner, and very little, as much as we're glossing over a lot of the issues of the patients, you know, we're not even trying for it's very often, for the
Mm-hmm.
caregivers, because it's just too much that we just don't have the bandwidth for it. But the way that their lives are affected, both during a patient's disease course and in the aftermath, if they lose their loved one, I mean, it's just absolutely horrific. So yes, absolutely, bringing them in. I believe there is a trial going on at Sunstone,
Mm.
um, with partner MDMA, joint sessions for caregivers, which I think is terrific. But yes, I think that when somebody is diagnosed with cancer, their whole family is affected. It has such a ripple effect on, not just the spouse, but children and siblings and coworkers. And I mean, I'm not suggesting that absolutely everybody needs to do this, but there's an uh, enormous amount of suffering and grief, and trauma that can be really helped, for some people. affected by this, and it's, yes, definitely goes beyond the patient for sure. Even people who are at high risk for cancer, and that's a huge population, or living with that specter, who actually haven't had the diagnosis, or people who have like a low-grade prostate cancer and they're undergoing watchful waiting, and it may become a problematic cancer, or maybe something that they can live a normal life with, and every 6 months they have to have a transrectal biopsy. It's horrible. There's a lot of people at risk for cancer who I think really could benefit by doing this sort of work.
Mm.
Yeah.
So the way you phrased it was interesting to me, because there's this idea that we're just very individual things, not part of systems. But I think like almost we're more part of systems than we are individuals, and kind of this systems awareness is kind of a
Yeah.
cool insight that I think often can come from psychedelics, and help us, because we come from this hyper individualist thing. And so how do we become more communal in orientation? Maybe not communal, system, just community aware.
It's funny because that's almost like a metaphor for cancer itself. You have this group of cells that are constantly communicating and working for the greater good of the organism. And one of the really amazing things about cells is that when something is not right, they stop replicating. There's a self-check system. There's P53, that before a cell divides, P53 says, wait a second, let's just take a look. Let's make sure this makes sense. And in cancers, P53 is one of the most most frequently, the TP53 gene is very frequently disrupted in cancers. So, they're just sort of growing and taking and expanding without really taking in the signals from the community and giving out signals. It's sort of this very self-serving action. So it's almost as if these cells have been cut off from community and from this sense that you're describing. So it's happens on the macro and on the micro.
Yeah, that's interesting. So what are some frontiers that you're really interested in here around this intersection of psychedelics and oncology?
Yeah, I mean, I'm really starting with the basics here. Like, I can foresee the end, but I really need to start at the beginning, by just starting with the messaging and the education. And I think there's such limited understanding of what psychedelics are and can do, and how they can be worked with, and what the risks and potential benefits are, and how they can potentially help the cancer ecosystem. So I think just talking about it really is the most important thing initially, because I would love a time where people have a healthy relationship with death, and live for love rather than out of fear, and our ICUs are not crowded with people like desperately trying to get that last chemo and that last breath, and filled with tubes. And I mean, there's there's so many low-hanging fruits I can go on for hours talking about all the things that I think could be improved. But I really think just getting the message out, and giving people permission to even think about this and ask these questions and talk about it, and say, hey, this is something that could really help, is really what we need. I remember finding out recently that only something like 18% of Oregonians knew that psilocybin-assisted therapy was even legal, which is, you think about Oregon, it's so far ahead of the curve and everything, but just starting the conversation. So I'm trying not to think too big and too far ahead with all of this, but certainly, I mean, if I were pressed to answer this question, I would say two really big things that I would like to see studied are the biologic effects and the financial effects, because I think these are things that would get people to notice. The biologic effects would get patients to notice, and the financial effects would get the system to notice. And I think that, very often the question is, oh, well, these, you can't make any money selling a natural product, and how are we going to make space for this, and blah, blah, blah. And, I think, I think that the system as a whole would be incredibly benefited. If I have some patients who've worked with psychedelics, when I was in practice, and when I see them, it was a totally different story. We wouldn't be going over and over the same questions and the same, what's going to happen to me? And I looked at my tumor markers and they look horrible, and my creatinine. We would talk about their lives and their plans and their dreams, and really just, we talk about their cancer care, but we would not have to scrutinize every little thing and worry about the future. And I really think I could see twice the number of patients in a day who were taking mushrooms than patients who were not, and all of us get home happier. I mean, and so
Yeah.
I think that there's such a cluttered, system right now that can be uncluttered and happier and healthier. And I think there's the potential for that's tremendous. And I mentioned ICUs. We spend so much money, so many healthcare dollars on end of life care, meaning the last 2 weeks of life. And I think that comes from people who have not examined their relationship with death, and who are living in fear, and fighting for every moment in a way that's really not realistic or in the best interest. And so often, and this is true also for doctors. I mean, there's a time in a patient's journey who has advanced disease where there comes a time where treatment is going to do more harm than good. And so often patients receive treatment beyond that point. And I think that that's because of, the doctors who are not comfortable saying no, which is a hard thing to do. And the patients who say, well, I'm not going to give up. I must fight. And even though we know that so often in that situation, lives are shortened by giving too much chemo, complications are increased, more time is spent in the hospital. But still, these things are done for reasons that have more to do with trauma than with rational medical decisions. So I think that people who are making peace with death would not be ending up with multiple tubes in the ICU doing unreasonable things. And I think anybody in medicine who has witnessed this knows how absolutely horrific it is, and devastating to patients and families. And if we could stop this madness, not by mandating it, but inviting people into a space where they can, make choices that are not based on terror, we would have a better system. And I mean, there's so many areas. There's so much suffering that goes on in this journey. There's so many areas that can be helped, but those are a couple of big ones. And so biologic effects, I see this in a couple of different ways. I think it's not realistic to say, okay, well, if you have cancer and you take a mushroom, your cancer is going to get better because mushrooms treat cancer. I mean, that's obviously absurd. But I do think that working with psychedelics or doing inner work in general can help people improve their bodies and their minds in a variety of ways. And perhaps be better able to go ahead and undergo treatment and allow the body to do its thing. I think in the last 20 years, the major advance that we've seen in oncology has been cancer immunotherapy, which has been an extraordinary transformative era. And one of the incredible things, there's a variety of huge blockbuster medicines that have been made. But most of them don't actually do anything directly against tumors. What they do is they basically give permission to the immune system to do its job. And it's a testament to the unbelievable capacity that our bodies have to heal themselves. And that sometimes there are just barriers to doing that. And I think that's also a nice metaphor for the, the psychedelic journey as well. But I think that if we are to, clear our channels and clean our vessels, then we're going to be better able to make use of some of these natural healing modalities that are there for us. And I think when we're cutting down on polypharmacy, meaning, if we're not taking all these opiates and gabapentin and SSRIs and benzodiazepines, and I can assure you that there are tons of patients who are on enormous lists of these medications that are, marginally at best benefiting from them. And I think when these are removed from most patients' lists, they're going to be living better, happier, healthier, and they're going to be more able to receive, the benefits of their treatments. I have, through the years, heard a variety of anecdotes about healing of cancers, and they're mostly related, almost completely related to people who have worked with ayahuasca. And I think that's something that needs to be looked at. I'm really curious about that. I'm really open to the possibility of that. Part of my interest in all this actually started with this patient who, really incredible story. She had recurrent ovarian cancer. She was getting seventh line chemotherapy, topotecan, and it was sort of having a marginal benefit for her. And she actually went down to South America to spend 2 weeks at a retreat with a shaman. And no psychedelic medicines, really just the shamanic rituals. Came back and, was really not doing well. So we said, something, let's just take a break from the chemo. And she subsequently had a spontaneous regression of her disease, which almost never happens in ovarian cancer. It's next to unheard of. And it went on for about 2.5 years. It was incredible. She had a belly full of tumor, high-grade serous ovarian cancer, platinum refractory, like the real thing. And I had this 2-year regression, which was extraordinary. No chemo. CA-125 plummeted, scans got better, belly got better, got off all her pain meds shortly after this experience in the jungle. And so ultimately, the disease started to grow. Half her tumors started to grow. Half of them were shrunken. Took her to the OR, did a heroic 12-hour surgery on her, cleaned her out. The surgeon labeled the tumors as either shrunken away or growing. And the surgeon and I said, we got to look at this. And we put together a team of laboratory scientists who studied this extensively. And when we see something called a mixed response, where some tumors are growing, some are shrinking, we generally presume that that's because they're resistant clones that appear in the body. That's sort of been the presumption in oncology. But what we found was that these tumors were genetically the same all over the body, whether they were shrinking or whether they were growing. The key difference between the growing tumors and the shrinking tumors is that in the shrinking tumors, you could see infiltrating T cells. That's an immune cell that are capable of killing cancers throughout the shrinking tumor, eating them up. Whereas in the growing tumor, you could see that they were excluded from the tumor. They were sort of on the outside of the tumor trying to get in. They couldn't get in. And so clearly something immunologic had been triggered in her, shortly after she had this experience in South America. And can I say for certain that that is, what happened? No, the timing of it was really interesting. And so, who knows? This was in Cell, which is like our leading, it's a big publication, but we didn't mention anything about about the shaman. But that certainly piqued my interest. Like, what happened here? What happened? And I think we have to be open to asking these questions, right? We need to be. I know that, I had a lifelong cat allergy, and I inadvertently desensitized myself just by visiting a friend with a cat for 2 weeks. I didn't have to get
Andy Wheel story.
Yeah, I mean, there's other things that happen with the immune system. There are ways to turn it on and off. Our gut has a huge effect on this. Perhaps our, glucocorticoid response that's constantly triggered in this fear state is going to be suppressing this. I mean, there's so many things. And is ayahuasca changing our body to making us, more, to allow the immune system to do its job? Maybe. I mean, I think these are questions we need to be asking and investigating. And
Do
I
you
don't know
think
the
it's
answer.
possible to do this, like in the near term? Like, do you think if you partnered with, I don't know, Rutgers, just because you're in New Jersey, like, do you think this is something that could theoretically be executed on? And it's a little cartoonish for me to think you could do this in a
Yeah,
single population with a single type of cancer, but
yeah.
I don't really know how we would do that.
It's a little more nuanced than that, because you
Hmm.
don't want to turn the retreat setting into a clinical laboratory, right? This is a very beautiful and personal experience
Hmm.
that people have, and I'm the last person who wants to interfere with that. And I I remember I heard about some woman who had ovarian cancer and treatment wasn't working, and she went to the jungle and she experienced ayahuasca, and the story was that everything went away, and that she ended up staying on and just stayed there for years and became a curandera. And I really wanted to talk with her, and I had a friend who went down, and she said she doesn't like to talk about it, and you have to respect that, right? Like, I don't know what her process was to achieve that, but if that's something that she needs to hold on to for herself, um, that's her. You have to respect that. So, I think that we can't be just looking at people as subjects, but at the same time, this is important information. So these issues really need to be brought to the fore, because we can't really look at this from the usual scientific perspective. It's just not right.
Hmm.
Um, so I don't know. My hope is to somehow bear witness to this without interfering with this.
I love that. Yeah, we're kind of something we champion here is how do we just think a little bit broader about this you know scientific investigation topic. We can get really atomic and I don't know, it's kind of in this logical positivist frame, but once we have a few experiences we think, oh, perhaps we can do science a little bit more skillfully, be a little bit more efficient with our scientific spend, and then hopefully bring it into clinic in a nice, great, safe way, and powerful way. And yeah, it's a tough one. We'll figure it out, but it's
Yeah.
definitely something that I think many of us are looking at. And I'm excited for you to be at Penn for this upcoming conference. So I hope you find some allies and colleagues there that want to talk about this.
I hope so too. I mean, really, I'm driven to help serve patients and families, as I was saying, and caregivers. But I really think it's critical that it starts with the healthcare system, and not only because healthcare workers really need this, it could really personally benefit from it, but ultimately, it's not going to reach patients, or not going to reach patients in a good way, if
Hmm.
there's not good psychedelic literacy in the healthcare community. So I ideally that there's a lot more people with experiences who are talking about this, but at least hearing about it, knowing about it, and having resources, I think is going to be critical.
Yeah. So if you're in the, I don't know, y'all call it the tri-state area. If you're in the tri-state area, go check out this conference at Penn. It's coming up. It's going to be amazing. It's a very, um, I went last year. It was a lot bigger, but this looks like a really stacked lineup. It should be really interesting, and I love that it's. I just love the lineup. I love what they're trying to do this year. So I wish I could be there. Have the best time, Jason. And anything you want to like point people towards before we wrap here? Where can people follow you online?
Sure. I mean, my venture, if you call it that, is still in its infancy. I have a website I'm just putting together now. It's called psychedeliconcology.com. I'm on Instagram, Psychedelic Oncology, and hopefully we'll start posting something soon. But reach out to me. You can send me an email on the website, and if you want to connect with me, just reach out. My email is drkonner@psychedeliconcology.com. So I'm here to field questions. Yeah.
Outstanding. Well, thank you so much for your time, and I hope we get to do it again in the future. And best of luck out there on your ventures.
I really enjoyed speaking with you, Joe. Thanks so much.
Yeah, likewise. Thanks.
Take care.